Hello, and welcome to the Neurocritical Care Society Hot Topics podcast. I'm your host, Dr. Nicholas Morris from the University of Maryland Shock Trauma Hospital. And today I am very excited to talk to Raj Dar. Raj is a professor of neurology within the Division of Neurocritical Care at Washington University School of Medicine. And he's here today to talk about what I think is a real triumph and a really important paper for all neurointensivists to know about. His work on intravenous levothyroxine for unstable brain-dead heart donors, which was published in the New England Journal of Medicine in November of 2023. So, Raj, welcome to the podcast.
Thanks, Nick, and thanks for that introduction.
Well, first of all, congratulations on a New England Journal publication. In neurocritical care, these are sort of few and far between, especially led by neurointensivists. And I think the amount of work that went into this project was obviously immense, but this work started long before the publication of this manuscript. Can you take us back to a little bit about when did you start thinking about this topic and what got you interested?
Yeah, no, it has been a long journey and mainly a fun journey, I'll say, and unexpected, as sometimes research can be. Just takes you in directions that you have a clinical interest in, and then it just develops. And sometimes the avenue doesn't develop into anything. I think we all know that. And, this was one area that grew and developed maybe even more than I expected. And it kind of came out of, I guess, two related avenues. One being, of course, the fact that we care for patients in the neuro ICU who are herniating, who are brain dead even. And so, we see post-brain death care, even though we haven't declared the patient brain dead yet, when we manage, vasopressors, and we manage the hemodynamic instability and endocrine problems, lung problems. So that was, the clinical interest was always there. And then I think the second part, which has been about 10 to 15 years now, was really working more closely with the OPO here in this region to optimize the care even after brain death. And so that started 15 years ago. And, here we really have, now it's no longer so unique, but at that time was a pretty unique opportunity where the OPO had its own donor care facility. Now that's becoming more common around the country. And they were very interested in optimizing care, optimizing the science, which was, and still is to some degree, a unique aspect of OPOs. Not all OPOs looked at donor care that way from a scientific lens. And so that was appealing to me to say, we know there's problems going on. We know there's issues, as we can discuss, but we also have the opportunity to manage donors in an ICU, all the donors, so not just donors at my hospital, but all the donors in the region. And so I was able to get involved with donor management at the individual donor level and also the research level, really across the region. And so that was really a catalyst for some of the studies that we can talk about that I got involved in over the years.
That's fantastic. And I think many of our listeners will probably be well aware of sort of the ultimate inspiration here. But maybe you can help frame this work for them. Why is it so important that we learn how to stabilize brain dead donors?
Yeah, I mean, it's sort of a unique area where really, obviously the patient we've been caring for is deceased, but we really have this opportunity to provide organs to save lives. And so there's a lot of instability that happens after brain death, based on just the loss of brain function, the loss of input, potentially the loss of hormones. And, the more unstable a donor is, the less likely they are to be able to donate their organs. And so that potential good that can happen in this situation, when there's often a tragic situation that's occurred, really motivated me and inspired me, and inspires a lot of people in this area at the OPOs, and less so on the intensivist side, although it's growing, to say, what are the interventions we can do to make the lungs better, to make the hearts better, that ultimately can lead to those organs being transplanted. And then on top of that, the heart and lungs is mainly what I focused on in my research. But of course, if the heart and lungs are not working, the other organs don't look so good, kidneys, liver. So really, it has a downstream effect in terms of, if a donor has a cardiac arrest, which certainly can happen, that jeopardizes all the organs. So I think stability is really a key in donor management.
Yeah, absolutely. Especially when there's such a shortage of donors out there and such a high demand for organ transplantation. What do we know about the neurohormonal physiology of the brain dead donor? obviously you're really have focused in on IV levothyroxine supplementation. What do we know that happens during brain death to the thyroid hormone and the pituitary axis?
Yeah, no, I think it's sort of I would say maybe a misunderstood area or at least a controversial area because, I think most of us accept that there's going to be changes to the, in almost all donors to hypothalamic function, to some degree of pituitary function. But I think what's been unclear is how much that affects downstream, like thyroid function, adrenal function, and then the end organs like the heart or even the lungs to some degree with adrenal function. So there's been a lot of interest over the years in how do we link the observation that is incontrovertible that donors are unstable, that they have organ dysfunction, they have inflammation, and the observation that some donors have hormonal deficiencies, whether it be, obviously DI, but also low levels of corticosteroids or thyroid hormone in this case, and how are those linked? And, does obviously replacement of those hormones make a difference? So I think that relationship has been unclear and, it's a correlation. And that's what we want to test in this study is there really a meaningful therapeutic implication? And I think there was uncertainty there, both from a trial point of view, but even the physiology, I don't think it's entirely clear, as we may discuss. Most donors are not, in fact, that hypothyroid, and that was one of the interesting things we found here.
Yeah, I think that's surprising to many, perhaps some inexperienced people in the neuro ICU, but actually probably experienced people as well. Because I think, as we talked about before we went on air, maybe this is not a patient population, if you want to call it that we think much about and much about their physiology. At least not all of us do, and probably few of us do as intensely as you have. So this, as we said, this work didn't just come out of thin air. You'd sort of been building up to this for some time. So can you take us through some of your earlier studies and what you found and how you kind of built a case to have this large randomized trial involving multiple OPOs and really at a large scale?
Yeah, no, I think it was a really interesting story in the sense of unexpected and kind of the way that research doesn't always work, but maybe sometimes fortuitously does develop, and you have to have the right milieu, you have to have the right interest. And so it really did start with that one center, one question. And really the first question we actually looked at was corticosteroids. Just briefly, we had the observation that a lot of, and the other part of this, I guess, is a lot of donor science or donor care is not based on a lot of science. It's based in observations. It's based in, transplant teams saying that, well, I think there's a lot of inflammation. Let's do this. And so there was a practice that high doses of corticosteroids probably are helpful to tamp down inflammation in the lungs and the kidneys, maybe. And so the practice was to give very high doses of steroids, like a pulse dose, essentially.
Mm-hmm.
And so it was really nice in the sense it was just a bunch of intensivists, not all neurointensivists, actually sitting around a table over dinner saying, we're doing this. What is the basis of this? Should we do it? We know in sepsis and in the ICU that, steroids have a role maybe, although even that's not clear, but probably not this high dose of steroids, even for hemodynamic, that was around the same time in 2010 that a lot of those sepsis studies were coming out. And so we actually started, and it wasn't a randomized trial, it just shows the progression of the studies. That's really nice and interesting, that we kind of did a historical control study where we kind of started using low dose sepsis dosing of steroids and looked at things like glucose obviously was different in those groups, but also did the lungs work as well? Was the oxygenation good? Was the heart as good? And so that was kind of like the first simple study that anyone could probably relate to, just saying we did something in the neuro ICU like we all do sometimes, and does it make a difference? Do we really need to do this in subarachnoid hemorrhage or whatever? So that was the level that we started at, and we published that and saying that maybe these lower doses of steroids, we didn't go with no steroids, which is interesting. This thyroid hormone study,
Mm-hmm.
we were really eventually got to the point of no hormones here, but we were not at the point back then to say, and this is mainly based on the kind of beliefs and lack of equipoise, I guess you could say, in the transplant community, to say, well, we're not going to give these donors steroids, and then what happens to the recipients, right? There's a whole level of ethics that comes up in these studies that is something new for me, at least, as I've got involved. We don't think of that when we do something to a patient. Well, what happens to their children
Right.
or whatever? Like it's a whole different level of concern. And so we did low and high dose steroids and showed no difference in lung outcomes. And as an example, that did affect our practice. And we'll come back to that with the thyroid study, I imagine. And it also affected several other OPOs, not many, I'll admit. And that taught me that you can do these studies. You can find something interesting, may not be a randomized trial, but it could affect OPO practice, but it's not going to change all OPOs practice unless you do a large randomized trial. So that's kind of where and we did several other studies, pilot studies of thyroid hormone. We did one of my favorite studies, a prone ventilation study that we did before COVID, before proning was cool, I guess. And,
The OGs of proning.
at least, and it was really neat that we could just make these lungs work so much better when we prone them. And like the rate of transplantation, which as you alluded to is a real deficiency, especially lungs, are in great short supply. Only 20% of lungs from even young donors are utilized, and it's amazing. And so the heart is maybe, 40%, still very low, even when you have, young people becoming brain dead. And so that was really, it was also not a randomized study. So again, to that point, that we really wanted to work towards this definitive study. But the pronin study was really convincing. Double the amount of lungs were transplanted. We had physiologic endpoints. We even had CT scans showing atelectasis was improved. So, it was a journey. And then the final part I'll say, which really is important to this and relevant to our community, is that there was a community of OPOs and researchers, even not in OPOs like myself, who met and started to form a collaborative, maybe like NCS is trying to do, that we would meet twice a year to talk just about research. And it was a small enough community, like NeuroICU is a small community. It's not, thousands of hospitals. I mean, maybe it is now, but, these were like 20, 30 people meeting every year to talk about, well, one day we should do a thyroid hormone study. Like, this was, and that was called the ODRC, the Organ Donation Research Collaborative. And we met and over the years, talked about these studies. And that really helped to make it a national, to take it from the one center proning study, steroid study, to what we'll talk about today. And towards the end of this last decade, I guess, the 2010s, I became the chairperson of that collaborative. So that became kind of an unexpected, like, oh, now I'm actually really involved in this. So yeah, there was just a growth of so many things that were sort of fortuitous that brought this study to a realization.
That's great. I think you've actually provided a really wonderful blueprint for sort of young faculty, junior investigators, where they start kind of with maybe retrospective observational studies. They move into the prospective single center domain, and then they build collaborations and eventually take that to a much grander scale.
Exactly.
Maybe we can move on a little bit to the kind of thyroxine story. And so, as you said, during this work, you sort of transitioned away from corticosteroids and really focused on thyroid hormone. And in this study that we're going to get into more in depth, you infused IV levothyroxine or T4, right? But you've done some previous work because the more active form, of course, is T3. And you've, I think, done more than anyone looking at what actually happens in brain dead donors when you give them thyroid hormone. What type of thyroid hormone should you give them? Can you summarize some of your early findings for the listeners?
Yeah, I mean, I think first it's important, as we were alluding to with the science and the knowledge, it was pretty deficient, but when we'll go more into detail, but there definitely wasn't a study like this, but there had been, in a sort of the progression of science as well in many fields, including neurocritical care. I feel like there's maybe animals, there's a problem, which was in that case in the 1980s, heart transplantation became a bigger thing. And then there was a problem that, well, these hearts don't work that well sometimes. And why don't they work? And is it the donor's fault in a way? And so there was the experimental observation in monkeys, especially, or, non-human primate models, that maybe thyroid hormone and T3 could really jumpstart these hearts, and that deficiency that we alluded to earlier after brain death might be significant. And so, I can kind of understand, and this is, 4 decades ago now, that's a pretty exciting potential that you can make the heart work in a recipient better by giving the donor a thyroid hormone. And there were, small animal studies of that, but it kind of grew into, and that was mainly with T3, but it kind of grew over the decades into a clinical practice, as these things sometimes do, without having a definitive trial, saying, well, that made sense, let's start doing that. But a lot of those studies in humans were with T4, meaning levothyroxine, and mainly because of cost. To be honest, I think it was just T3 is much more expensive, and I'll come back to T3. But first of all, that use led to then, as it does in many areas, well, let's look at this retrospectively and who got, whatever treatment for subarachnoid or something. And so those studies came out in the early 2000s from, a decade or, 20,000 donors showing the donors that got thyroid hormone, mainly T4 in this case now, were doing better in their organ function, in terms of whether the heart was transplanted, whether total organs were transplanted. And so that was very appealing at the, I'd say, semi-scientific level to the opioid community and to the transplant community to say, well, this is great. It's translated over to humans. And so that was the level of evidence. And then there were some studies with T3 in humans, but they were all very small up till, and we did a study that I'll mention, that really, and that's again, I think a real learning point for me and for the community, is that there were these large retrospective studies, looking at databases with all the biases and confounding that hopefully we know about. But then there was, small randomized studies saying, we're going to give T3 to these 20 donors, look at their echoes, and none of those randomized trials showed any benefit. But yet we all, the opioid community looked at those large retrospective as more powerful, and that was kind of the world that we lived in up till we did our study, was this kind of equipoise, but really people leaning towards using thyroid hormone. The guidelines mention it. And then the T3 question, well, yeah, the studies didn't show a benefit. And then we did a study because we were like, if we're going to go forward with this, we want to know definitively. We don't want someone to say, well, you didn't show benefit with T4, but maybe T3 would have been better. So we did a pilot study, which was also important for, sample size and all the things we think about. And where we took unstable donors, sort of similar to this study, and randomized them to T3 or T4. What was really cool in that study, and briefly I'll mention one of the advantages of opioid research, is you have a lot of flexibility in interventions because these are not your patients, these are donors you're trying to optimize. So we could do echoes serially. We had the ability and the resources, to be honest, to do echoes in that small pilot study. We didn't do serial echoes in this large study. Unfortunately, that wasn't feasible across 15 sites. But in that small study, we actually did a baseline echo immediately after brain death declaration, which was super interesting, I think, as a neurointensivist, is like, how do those hearts actually work? We all know about Takotsubo, and we know about stent myocardium. And we did find that in those unstable donors, again, selecting those on pressors, their incidence of low EF was very high. I think the median EF was like 40%. If you do the echo early enough. And it's interesting, as I learned on the outside of the opioid world, no one does echoes that early because no one wants to find a low EF, because who wants that heart? So, that's sort of an aside. But
right.
There's sort of interesting, like, oh, the echoes we do are fine. Well, that's because you do them a day or two later. So we did it early, and then we gave T3 or T4 in a random manner in this small study, admittedly. And then we measured echoes again in 8 hours after intravenous infusion of both drugs, and we showed no greater rise in the EF. What was most interesting is the EF went up in both groups. So there is reversibility even over 8 hours, which to me, again, is very interesting. So, there basically are several lines of reasoning based on use. The majority of opioids are using T4, not T3. The randomized trials not showing the benefit of T3, our pilot data. So that was the main reasons why ultimately we ended up doing the thyroxine, not T3 study.
Great. And from a sort of logistical standpoint, I imagine this was quite an undertaking. It sounds like you were maybe able to manage this through building this collaborative that you described previously, with yearly meetings and things. How did you convince the OPOs to take part? Because I think a lot of neurointensivists have experience working with OPOs, and if anything, they're very committed to their policies and guidelines, and it can be quite difficult to change some of these really strongly held beliefs about what's helpful for the brain dead donor. So yeah, how were you able to get them all to get buy-in?
Yeah, no, that was a key point, and it did take that kind of decade. It was a decade from when we started talking about the T4 study when we did it, and even though there were 15 OPOs, and if anyone's interested, I'll point them to the supplement of the paper where we have a nice map of the U.S. and these different OPOs that participated, and I was really impressed, and I certainly don't take all the credit for it, of getting these OPOs on board, and the geographic and diversity that we got in our study was nice, but it's still 15 out of over 50 OPOs. To your point, that means that other ones that we approached did not participate. So it kind of shows you that there are barriers. But I think they're starting to become more open, especially if you go from within and kind of my collaborator, Gary Marklin, who's the chief medical officer here at our OPO, was also on the medical directors board. So kind of talking face to face. So definitely without him and without kind of that community of trust, that this is not, we're just coming from the outside and saying you need to change your practice. We like their role, which we can identify with, but I think they do it even better than we do, is mission focused. As you said, it's just we want to get more organs. And so you have to turn that mission into, well, we need to do better science to get more organs. And I think we did convince many OPOs of that there's a benefit to knowing if what you're doing is working. It's not, but yeah, that was a learning process. We did these small studies. We did small collaborative studies. We actually did a 4-center randomized trial that to me was interesting. That was a trial of Narcan. Narcan, interestingly, in animal models, reverses neurogenic pulmonary edema with herniation in sheep. And so a lot of OPOs were using Narcan. And I was like, why are you using Narcan? They're like, oh, yeah, based on these sheep studies. And I was like, I'm not sure that's the best basis for human treatment. I mean, it's interesting. And so doing a pilot study with just 4 OPOs for me to learn, how do you get them on board? How do you randomize? And we did that study and showed naloxone has no benefit in lung function after brain death in humans. So, the kind of track record, and then going back, said we've done the Narcan study, it worked, no one kind of freaked out. So it was definitely a complex building of trust, of the kind of scientific mission, I guess. And then the help of Gary Marklin and others in the community was really key. And then some OPOs still didn't. I mean, to your point, some really felt that thyroid hormone works, and why would we want to randomize? So you had to find OPOs that had equipoise. I will say, impressively, also in the supplement, there's a nice table of all the OPOs and which ones were using thyroid hormone, which ones were doing, high dose steroids, all that kind of stuff. And except for a few, they were all using thyroid hormone. And so I really do give credit that 12 out of 15 OPOs randomized donors to no thyroid hormone, even though that was their protocol. So to your point, I mean, it is hard, but it's somehow possible to convince OPOs to try something different, as long as it's, and I'll add one thing to that. We had 2 safeguards, so you have to build in safeguards for trials, not just for patient protection. Here, it's not patient protection, but we still felt there's an important safety, both donor protection and recipient protection. So we had a DSMB, and we had the option, as maybe we'll briefly discuss, to have open label rescue therapy with T4. And that was, again, based on your question, is we needed a way to convince OPOs, well, yeah, if this all goes down south and the donor's unstable after 12 hours, you can still give them thyroid hormone. So actually, that might have been the other part that we had to, accommodate or be flexible. Obviously, to me, I would have preferred having a totally closed study and no open label and no blinded. We can talk about blinded, and that was very difficult. So there was things we had to accommodate. I think hopefully they didn't really weaken the study too much, in my opinion, but they were things that were kind of compromises, I guess, to make the study feasible.
Yeah, I think that's so smart, and this iterative process you've gone through, I think as an outsider looking in, is it's just really impressive, and I think culminates with, a manuscript that really grabs attention. One thing that, again, as a neurointensivist who probably doesn't consider management of brain dead donors enough, one thing that I thought was interesting here is, as you sort of build this case for equipoise, is that there may actually be harms, right, from administering levothyroxine, as opposed to just benefit or no benefit. And I think you'd shown that in one of your previous studies. So can you talk a little bit about what those harms might be and why someone maybe doesn't even tolerate levothyroxine?
Right. Yeah, we definitely, and that's another benefit of the pilot study, is we really learned and modified our protocols to allow weaning of the drug, as I'll mention, and also discontinuation and monitoring for adverse events, because it became clear to us that, especially as you come off pressors, obviously when you're on pressors, hypertension is not so much of a problem, but as you stabilize the donor, which happens inevitably, to be honest, without levothyroxine, as we showed, then the risk of continuing the levothyroxine is just the blood pressure keeps going up and the heart rate goes up. And in our pilot study, there was 2 pilot studies. One was the T3 versus T4. One was just T4 versus placebo. The difference in the T4 placebo, which was, again, the more true comparison to this trial, was they didn't have to be unstable. They just had to have low EF. So those donors weren't hypotensive, and we really found all of them became hypertensive, so that was really eye-opening, that we needed to be careful. One, which we did, allow a protocol that allows you to titrate the drug, which, I mean, it made sense, but
Hmm.
it wasn't like everyone has to run it at this dose for all hours, regardless of blood pressure. Uh, and we can come back to that. Actually did help, I think, reduce serious adverse events. But we definitely saw a high incidence of hypertension, tachycardia. We were worried even about cardiac arrests. That's the last thing you want, obviously, in a donor.
Yep.
And so, yeah, no, there's definitely can be harm from any treatment. And that's ultimately why we did it, is even if it doesn't work, some people may say, well, but maybe it helps a little bit, we can do it. But no, there's also a
Yeah.
downside
Yeah.
to doing things. And so that was definitely something we monitored. We had a DSMB, like I said, which is all, all part of the learning for all of us interested in clinical research, is like going through a study like this. It's just, there's so many things you learn that are valuable regardless of the intervention. It could be Narcan, it could be levothyroxine, it could be steroids. But yeah, the DSMB was fascinating, putting that together, multidisciplinary, with an ethicist and a thoracic surgeon but it was interesting. It was fun, to be honest, to get their input. We also made changes based on what the thoracic surgeon said, what the ethicist said, made sure you inform the transplant team. That's why it can be blinded, actually, because the transplant team turned out wanted to know if the donor had received levo. We thought would want to know in case
Hmm.
they're like, we're not taking this heart because they didn't get levothyroxine, and then a heart could not be transplanted. We wouldn't want to be responsible for that. So that was one of the reasons. Not only was it not blinded, but we actually posted in the transplant. There's a website, a registry that they look at called DonorNet that all OPOs use, and we actually posted in the comment section, this donor is randomized to the study. They are receiving saline, et cetera. So that was all part of this ethics feedback that we went through. So yeah, there was a lot of learning that definitely I had to do to go through the study.
Yeah, and I think these lessons really can generalize across neurocritical care. I don't think it might seem to listeners like we're piling on OPOs, but this is actually, we're all guilty of this as neurointensivists, right? We're very kind of wed to certain treatments that we've done historically with very little data supporting them. I think we can learn lessons that from your experience with this, and hopefully maybe we can use those lessons to study things like management of DCI and subarachnoid hemorrhage, right, where we
Right.
run
Absolutely.
into all these same biases.
Absolutely.
Maybe
100%.
we can transition a little bit to getting to sort of the meat of this paper. So can you take us through what patients are you actually interested in studying here, or what donors? I guess to use a proper terminology, were you studying? So you mentioned previously you had one paper where you looked at hypotensive patients, another one where you looked at patients low EF. What were the inclusion-exclusion criteria for this manuscript?
Sure. Yeah, and we chose in this study, obviously, brain dead donors. We weren't looking at, DCD or anything like that. And we wanted it to be relatively close to brain death, because that's another, caveat, is if obviously if you
Mhm.
do the treatment, 3 days later, it might not really help the heart that's already going through the brain death process. So it had to be within 24 hours, although the median time was 8 hours from declaration. So pretty quick. Uh, but yeah, importantly, they had to be heart eligible. So obviously if our outcome was transplantation of the heart, if you're, 80 years old or you have heart disease. So that was a major exclusion. But we also, to your point, wanted to focus on the use case for T4, which predominantly when we surveyed medical directors and OPOs was either, as you said, hemodynamic instability or low EF. And so that was really, rather than going at every donor, like, and we talked about this obviously for many meetings, do we want to include an 80-year-old donor who's unstable? Well, it might help with our instability question, but it doesn't help with the heart question.
Mhm.
We want to include, and we decided pragmatically we didn't, for the reasons I said, but also that we didn't want to just do it based on echo, mainly for the reason that I mentioned earlier, that we don't get echoes early enough. So it just wasn't pragmatic. You don't know. And thankfully, from our prior study, like I mentioned, when we looked at hemodynamic instability, that is a pretty good surrogate for cardiac dysfunction or instability. That we don't know what the average EF is in our study because we didn't have a baseline echo. That's certainly a fact. But based on our pilot data, we presume that it's a good surrogate, especially high dose pressors. And so we use that both based on the pragmatic equipoise question of when do people want to use T4, and also to kind of enrich the population. I mean, and we did lose some people, obviously, who were stable, although I think it was maybe 25%. I forget the numbers in the flow chart. But, there were some donors who are stable. And so we're like, well, maybe there's no equipoise. No one would maybe use T4 in those donors. So why
Mhm.
would we randomize them? So yeah, we focused on the unstable donors based on pressor usage.
Great. And can you walk listeners through what the actual intervention was?
Yeah. So we chose, as I said, T4, levothyroxine, intravenous. It's pretty accessible. Most OPOs have that. And most of them were using that, in fact. And we kind of surveyed the opioids and the dose, and we decided on this dose of 30 micrograms an hour. Opioids used between 10 to 30 micrograms as a bolus. They run an infusion, 10 to 30. And so we actually chose on the higher end, again, with a slight caveat that we might see hypertension and tachycardia, but we had a mechanism to adjust for that. But we didn't want to have it that we'd use a low dose. And then again, someone said, well, you just didn't give enough T4.
Mm-hmm.
So I think that was another discussion. And we ended up on this higher end of the spectrum of 30. And then we ran that for a minimum of 12 hours. In our pilot study, it was 8 hours. We kind of settled on 12 hours with the option that certainly the opioids could extend it, and half of them did, all the way to organ recovery, organ procurement. But at the very minimum, it had to be 12 hours. And for those 12 hours, importantly, the saline group could not cross over to T4. So that was the one caveat, that even though we allowed that open label later, as I mentioned, that was only after those 12 hours. And so we could at least do some endpoints at 12 hours, like pressure weaning, echo, without the kind of crossover issue.
Mm-hmm. And so there were some patients then that, as through the open label extension, were allowed to cross over in the opposite direction from placebo, I guess, to levothyroxine. Is that right?
Right. For the reasons that we mentioned, mainly
Yeah.
on the transplant side, we allowed that. And what we did was we discouraged it, meaning we definitely didn't want it to be like your protocol should just be always to start it even if the donor is unstable. And we collected and we forced collection of data on the reason you continued or crossed over. And we thought it could be, transplant request, it could be, whatever. But in fact, and it's in the supplement somewhere, out of like only 50, I think it was 50, about 10% of the 400 and something donors who got placebo crossed over. So a pretty small crossover rate. And out of those 50 donors, only 3 were due to transplant center request, which was super surprising. Like we thought that the OPOs were saying, no, the transplant centers will force us to use T4. That wasn't the case. It actually was mainly the OPOs saying, well, the donor still got a low EF. They still are on pressors.
Yeah.
And so you're right. There was this crossover. And obviously we did, sensitivity analysis and per protocol analysis, all that kind of stuff. And I will say the statistics were, just for our listeners, I mean, I went into the study thinking, I've done studies before. I might, start with the statistics here, but definitely lesson learned. If you're going to try to submit something to a high-level journal, do not try to do the statistics yourself. It got way too complicated very quickly, and I was very glad that WashU Biostatistics was able to help because it got really complicated. I mean, not just this part, but other parts like imputation of missing values and all kinds of sensitivity analysis and subgroups. So that was sort of interesting to me. I was like, I'm glad, and I learned a lot of statistics in doing this study. So I'm glad I didn't do it myself.
That's great advice. How did you choose your primary outcome?
Yeah, I think based on those prior studies, whether it's animal studies looking at the heart, that's just where the most rationale was. And when we talked to people, why do you do this? It could be the heart, it could be all thoracic organs, but really it was the heart that people cared about. Of course, there is the potential to improve all organs just through improving the heart, honestly. And so we had a secondary outcome of thoracic organs and all organs. But we felt that, the studies, the, retrospective, the prospective had looked at vasopressors, which, we looked at, EF, which we looked at, and heart. So really, when we kind of surveyed, it's not exactly like PCORI, it's not like patient outcomes, but it was sort of like OPO centered, like what do you guys really care about? And so we did a survey in a similar way you might do with a patient-centered outcome.
Okay. And maybe you can take us, what was your proposed effect size? And maybe that can kind of segue into us, how many patients actually did you end up enrolling in the trial?
Sure. Yeah, and based on our pilot studies, based on those other retrospective, we were like, well, what are people proposing? And it was as high as 20% difference in the two groups. But I think, we realized that's probably optimistic, and we didn't want to, power it so much because that would be a much smaller sample size. So we went with a 10% difference. The other part of it that was sort of statistically interesting, or from a trial methodology, was we proposed a superiority trial, meaning in the end, it didn't make a massive difference, to be honest, but it was sort of, you have to make your hypothesis. And I think that's it. The power-wise, it wasn't a big difference, I guess. But we said all we care about from the hearts transplant is, does T4 result in more hearts? We're not looking at like less or more, two-sided hypothesis. Purely, so that was interesting that we just looked at a superiority of T4 and a 10% effect size. And that gave us our sample size of about 800 donors. And so that was kind of where we started saying, how many OPOs do we need? How many years is this going to take? If it's going to take 15 years, like a carotid dissection trial, then you're like, well, we probably can't do this. So, so at least it was sort of feasible, but we needed, maybe 20 OPOs, 10 to 20, and that's eventually what we got.
Great. Can you take us through your main findings?
Sure. So the primary outcome was really hearts transplanted, which again, the good side from a methodology point of view is you don't lose any primary outcome. So even though I mentioned imputation earlier, that was really for things like echo findings if someone didn't have an echo, which did happen. But our primary outcome was really clean, that we obviously knew if the heart was transplanted. And one thing we didn't also mention so far is our co-primary outcome was, did the heart work in the recipient? And there's a whole discussion on that we may not even go into, but it's sort of interesting if you're interested in recipient outcomes that we included that for various reasons. And we also made it a safety outcome. I mean, there's actually studies suggesting that if you get thyroid hormone and then it's stopped, because inevitably the donor, goes through recovery and then there's no more thyroid hormone, and then the recipient doesn't have that, the heart won't work as well. And so actually there was a hypothesis that the outcome could be inferior in the thyroid hormone group. So there's sort of a whole line of reasoning there. So we had these two outcomes of recipient non-inferiority and superiority of the heart. So it's sort of a dual, but we had no missing data. And then interestingly, we got our recipient outcome data, which is a whole story about how we got that. And we did that through IRB because those are human subjects. And we got it through, a request to a registry that collects all recipient data called SRTR. But we were like missing one data point. We had, 443 hearts transplanted out of 838 donors in both groups. So we said, here, we want to know if these hearts worked. And we sent it to SRTR and they sent it back and they said, yeah, 30 days, this many hearts worked. But we're missing one. And we're like, what happened to this one heart? It was sort of an interesting, and I was like, okay, we don't have one missing data point. And then I was like, which OPO does this come from? It came from Life Center Northwest, which is in Seattle. And we said, well, what happened to this heart? Like, how come, like, oh yeah, that heart went to Canada. And so obviously SRTR doesn't track that, but
international borders, huh?
Yeah, they called the hospital in Canada and found out how the heart did. So that was really neat that we actually had no missing data for our heart outcome and for the recipient outcome. So that rarely happens in studies, I feel like, that you have no missing data, but our primary outcome was the hearts, and that was equal in both groups, or was not different in the two groups.
Yeah. And you all did some subgroup analysis too, right? Where you looked at patients specifically with low EF or normal EF if they did have an echo. And did you find any signals within those subgroup analyses that maybe some subpopulation benefited from the intervention?
Right. And yeah, we had these two pre-specified, and then we did extra ones later based on the reviewers. But definitely the most important one was the low EF, because we thought, well, maybe it doesn't work in all unstable, but it'll work in. And so I forget exactly what the percentages were, but there was a significant percentage that had low EF. And there was no difference even in that subgroup based on the echo findings of having low EF. We also looked at early treatment versus late treatment and other things that we can discuss. But actually now I remember, it actually was sort of interesting again because the echo was delayed at least 12 hours on average. So again, it's not a super early echo, but the frequency of a very low EF, less than 50%, was actually lower than we anticipated. We might have anticipated 20 to 40%. It was actually more like 10 to 20%. So it actually, one, was not as common by that time once you've given time for the heart to recover. So it's not as big a subgroup as we thought, but even in that subgroup, there was absolutely it was like actually a higher percentage of hearts were transplanted in the normal saline group than the T4 group. So we really felt strongly there was no signal that even those hearts needed levothyroxine.
Yep. And you all measured thyroid hormone levels in these donors, right? And did the patients who are deficient, did they seem to benefit more?
Right. And that we definitely measured it, and we had it for most, not all. And as I said earlier, it was interesting that only a minority, still like 38%, I think, total, were deficient. So less than half were deficient, but there were some. And they were not that deficient. It was just under the, 0.8, 0.9 level of normal for a free T4 level. But even in that subgroup, which was actually a post-hoc analysis, we didn't, for whatever reason, pre-specify. Yeah. Another lesson learned is, you make your protocol and you have to stick to it, obviously, when you publish in a good journal. And so that wasn't pre-specified, so that we try to sneak that into the main paper, and they said, no, it has to be in the supplement. So if you go to a supplement, you'll see the low free T4, high free T4. But yes, there was no difference in that. And we also looked at the vasopressor dose that we might talk about. And even because one of the reviewers said, well, what about donors who are really unstable? maybe they
Really
really,
unstable, right?
yeah, exactly. And so we looked at like higher vasopressor usage, basically over zero point 0.1 of levo on average, uh, of norepi, and we didn't find a benefit even in those very unstable donors. So essentially, we didn't find any subgroup, obviously with all the caveats of subgroup
Hmm.
analysis, that levothyroxine had a benefit in.
Yeah, and were there any improvement in intermediate outcomes like the vasopressor dose?
Yeah, and that was, the other funny thing was our primary outcome for many reasons was the heart transplanted for the reasons, that it's more recipient centered or whatever, it's more meaningful. But people said, well, we may or may not show a difference, but we definitely want to look at vasopressors because, you know, there's a strong rationale. And even if we don't show this, maybe we'll show that secondary outcome. And
Hmm.
then maybe we'll still use T4. And every single person who felt that was 100% committed to that being the benefit, even if the hearts weren't better.
Yeah,
And we actually showed, which was, I honestly didn't know where I stood. I was pretty much an equipoise on that one. I, you know, people tell me they start T4 and the pressure's dose comes down. And so it just goes to the fact that, yes, these practices that we all do, that we're like, yeah, it definitely works when we do whatever for, cerebral edema or something.
right.
It had no difference. I mean, the pressors impressively came down by half in 12 hours in both groups, and the other group was getting placebo. I mean, they got saline, so it wasn't like they were getting some other treatment. Uh, so yeah, there was actually no improvement in vasopressor weaning. And then of those that got echoes, which was a majority, not everyone, I think it was like 90% or 85%, there was absolutely no difference in the EF of those echoes. So those were the two main secondary outcomes. And really, we had no, I mean, there was just no signal. I mean, it was a little
Yeah.
surprising. I thought maybe we'd see, no primary outcome, but yeah, but maybe the echo slightly better, but it really wasn't.
No, I think it's almost we poured through the supplement data looking for this signal and it's just not there in your data at all. And I think it's fascinating. And I think for the first time it helped me understand what is the natural history of the brain dead donor, right? And
Right.
we don't know that
Right.
through all of our anecdotal experience. So this was, I think, for me, a really impactful study. And I'm just so appreciative that it's out there. Kind of wrapping it up, what effect has this study had on maybe your own practice or the OPOs in your region?
Right. Yeah, no, that was the first step was like, okay, now we've done this and kind of take a deep breath, present it to the OPOs that participated, and many were surprised. I mean, obviously, that we expected. We weren't so surprised because actually our OPO had stopped using T4, was one of the three that wasn't using it for a few years prior. And so, that's sort of a retrospective study, like, oh, we stopped using him, our donors are doing fine. But uh, so we continued to change our practice and not use it. And then a few other OPOs immediately changed. A few other OPOs, interestingly, said, let's wait for the publication. We see the data, but we want it to be published. I mean, it's the same data, but I guess it's more impactful when it's on paper, I guess. And then they changed. Some said we got to go through our medical advisory board, which is fine. And so, yeah, so generally, I would say the participating OPOs have been very receptive and we presented to them individually, to their groups, I presented at the OPO national meeting last summer, before the publication even. I presented to the transplant community at their national meeting, both in platform sessions, and got good feedback, especially from the OPOs, actually. The transplant community was like, okay, that's fine, whatever,
Hmm.
like whatever the OPOs want to do, even though the OPOs say it's whatever the transplant centers want to do.
Yep.
The transplant centers were kind of like, we don't mind. Like, if you show us it doesn't work, we won't force it, which was good. And the OPOs were really impressed in the fact that we could do this kind of science, I would say. And I think they'll also feed into future studies, I hope, that they'll be like, okay, can be impactful to our community. And so finally, yeah, I don't know if all have changed yet, I would say. And that's something we actually plan to do a follow-up survey, to see
Hmm.
like one thing I'm not an expert in, but I'd certainly love to hear people's feedback is like dissemination science and implementation. Uh, that's a whole challenge. And changing a 4-decade-old practice, I really think is very interesting. Like, how does a definitive study, that anyone can look at in publication, does it change your practice? And I'm very interested in a year's time when we survey these OPOs. So my anecdotal sense is many have changed, but not all. And I'd love to see how we can implement it better, disseminate the paper, disseminate, talks. I don't know, but yeah, I think it'll be really interesting to see how OPO practice changes as a kind of a case study in that.
Great. Well, I think you really provided sort of definitive evidence in this area. You mentioned that this wasn't the first kind of area of neurohormonal physiology you looked at in brain dead donors. Where do we stand with corticosteroids? Where do we stand with other treatments? And is that something that you're interested in looking into?
Yeah. Yeah, I mean, I think right now it's sort of a hodgepodge based on the kind of retrospective studies. We have the low dose OPOs that were maybe half, I forget, in our 15, and then high dose is still out there. And so, yeah, we're actively thinking and thinking of actually some new methodologies. There's a lot of clinical trial methodologies out there, like cluster randomized studies, et cetera, that you could do to really answer the steroid question more definitively. So that is something we're thinking about. And then, I think other questions are like, can we improve the heart with vasopressor sparing approaches? Like, we always think in our Takotsubo patients, or at least some do, or at times, are pressors actually hurting the patient since it's catecholamine-mediated damage to the heart? So that's another question we're interested in, is like, can we actually do things that promote the heart to get better? If thyroid hormone is not doing it, what can do it? So yeah, I think there's definitely future studies that the OPOs are open to now. And I think from my point of view, selfishly, I don't want to lose that momentum, I guess. I mean, I'm taking a year off at least. I was like, once it got published, I'm like, I'm taking a year sabbatical from any research, clinical research. I was just really, I mean, happy but tired after putting all this together for like 2, 3 years. So it was a 2-year trial, 1-year publication. So those 3 years were very busy.
That's fair. I think I'm interested to get your thoughts on this. So some of my friends and colleagues around the country and looking at these data have said, well, you mentioned this issue of timing, right? And I think clearly brain death doesn't happen at the moment of declaration, and perhaps sometimes there's a long delay between when we sort of suspect maybe cerebral herniation to occur and brain death, and then when the declaration occurs. And for that reason, some of my colleagues will start some of these therapies before declaration, which they think might be good for stabilizing the patient through apnea testing, et cetera. What do you think about that practice? And do you see that as a limitation to your data, or do you think differently about it?
No, I do get that. And I think that's sort of the limitation of donor research, is it has to be by definition in the donor once they're declared. I think as a neurointensivist, yeah, I mean, I agree that there's questions about, herniation management that this study doesn't answer, I guess. I would say I don't know whether these interventions would help. I sort of doubt it, but that's just my own speculation, like anyone else's speculation. I don't have, good data on that. I think what I would say, though, is this study was challenging but feasible. Those kind of studies are way harder to do in a herniating patient with consent and with these kind of issues. We got authorization for research from families, but not consent. And, there was less IRB issues, I would say. There's still IRB issues. So, I think that would be fascinating to do and think about. I wouldn't do it myself, studies, but I do see the rationale or the, I don't think our study answers that question. I don't know if thyroid hormone is the answer. Maybe it's, changing pressors. Personally, I think the idea, based on some very small studies, but it's just my own feeling, is beta blockade in herniation makes a lot of sense. Like we've talked, I'm sure you're aware, in the early Takotsubo studies, have been stuff out there a little bit. If we could do that study, I've been thinking about for years, but realistically to this audience, like, could we do that study? Like, I'd love to do that, but how would you randomize people who are herniating to an aggressive IV intervention? If we could do it, I mean, I'd be all for it. Let's get the community together, and that would be the intervention I would be interested in personally.
Yeah, and there's huge ethical considerations before declaration, which I don't know how you would possibly work around or get through an IRB.
So this kind of approach with some limitations is just so much more feasible. And the OPO community, like I said, there are issues that everyone in the neuro ICU probably is aware of, but it's getting better, number one. And two, this has really opened the door, I think, to research. So if there's more people interested out there, the community, I think, is open to that, and let me know or let your OPO know. And they're open to collaboration. So it's not a closed door, maybe like it once was.
Yeah. Well, Raj, thanks so much for joining us. This is such a cool story that unfolded, over a decade, it sounds like, or longer. What are some lessons that you can share with listeners who maybe they're not interested in brain death donors, but there's something that they're seeing in practice that interests them or frustrates them, and they want to solve a clinical problem? How do they get it from that kind of something I see on rounds type of thing to what you've done in putting out really what I consider sort of a definitive trial in the New England Journal.
Yeah, no, I think we've outlined some of the journey, and I think that's certainly taking those steps and having the persistence and making connections of other interested parties in that area, whether it be through, a subarachnoid hemorrhage conference or a focused, brain death thing or whatever area it might be. And I'm sure people are doing that, where you meet people and you talk but take that to the next level and say, hey, could we do a study one day? What does that take? And then the planning of the study, as we've also alluded to, definitely be very deliberative about, doing the personally, and I think the study is a perfect example, I'm maybe biased, is of what we need to do in neurocritical care. I know it's not easy, and that's will be my plug to take away. If we have junior people and even mid-career and senior people, I think we need to do more of this in our field, and we're not doing enough of it. I know it's challenging, but I think it takes commitment, and we had OPO commitment here, which made a big difference. Also, one thing we didn't mention is the study was not funded, which I'll say as an aside, the New England Journal reviewers could not believe, because if you look at every paper there, it's like funded by Novo Nordisk, funded by this. And they're like,
Right.
who wrote the paper for you? Who did this? And I was like, no one did this. It's just like us and two other people, so that's an interesting aside for the journal. But obviously, if you can get funding, that's a helpful thing. But definitely the planning and taking it through. But I do think we need to do these kind of trials. So it's like having young people who can get together, I think, and join, whether it's an NCS community of sites or you make your own community of sites. I don't know. But yes, plan. I learned a lot, like I've said in this thing, about getting the sites together, training them, getting the data forms together, putting the IRB together. There's so many steps, but I think there's senior people who can help you with that. I'm obviously happy to help. There's others who have done clinical trials. But yes, taking an idea to a trial is, I think, so important in our field, and we don't do it enough. So I would definitely encourage people to just be persistent. It might take a long time. Get the buy-in of the community, leaders in the community, like in my case, I was able to do. And, whatever stage you're at, if you show interest, like I did, and some kind of leadership almost, or just, I'll do this, I'll do the work, people will follow you, I guess. It wasn't through expertise that I did this. It was just honestly through hard work. And so I think a lot of people out there have that. And I think that's the future of our field. If we can do more of this in our field and have papers like this come out in all these areas that I'm sure you're aware of and the readers, but it's a challenge, and we need to maybe at the NCS level make ways to facilitate that. And I think there are ways that they're working on. And so I'm happy to help from my experience, but I learned a lot in this. And so definitely it's a wonderful learning experience, regardless of the specific study you're doing. I think it's been an amazing side job. I have my separate primary research in living patients. So this was actually just like, again, a volunteer position, but it's not the worst volunteer thing to do if you have a nice product at the end that makes a difference for whatever aspect of clinical medicine. I think that's really satisfying. So I would encourage people to do that.
Well, I think that you've clearly sort of paved the way for others to see how to do this type of work. And time and time again, we sort of think of these pipe dream research ideas that, oh, if only we could get people together and solve this really pragmatic question that we've all been wondering about, but we lack the collaboration to get done. And you've done that in one important area. I would ask you maybe one day to think about putting on a workshop at NCS on sort of the skills needed to do this, because it strikes me that a lot of them might be sort of technical skills, but it's a lot of non-technical skills. It's a lot of consensus building and collaboration. And I'm sure you had a pretty nice elevator pitch for these OPOs just to get your head in their office and get them to respond to your emails. And I think those things are so important, and we don't really teach that very well. And I think a lot of us fail at that step. As an educator, I would ask you maybe if you could share those lessons with us at NCS one day.
Yeah, and I appreciate your interest, and hopefully the audience too. This area, we don't always think about it, but I appreciate you reaching out and kind of talking through this with me.
All right. Well, congratulations again on a really wonderful paper, and we're so lucky to have you talk through it here on the podcast. This is the Neurocritical Care Society podcast. We are available anywhere you get your podcasts, and continuing medical education credits are available for select episodes. Dr. Raj Dar, thanks so much for joining us, and can't wait to see what comes next in your search to stabilize the brain dead donor.